I am now calling this regular meeting of the Boulder County Board of Health to order at time is 5:32 and the date is November 9th, 2020. We'll start out by asking all Board of Health members to identify themselves. I'm Greg Thomas. I'm the board president.
Brooke Harrison, board member.
Landry Fagan, board member.
Morgan McMillan, board member.
Hello, Morgan. And Jorge should be joining shortly, but we'll ask him to introduce himself once he's in. Okay, and then Jeff, if you wouldn't mind introducing yourself and the staff.
Yep, Jeff Sayak, Boulder County Public Health Executive Director, and staff that are on the call, and then I'll ask if I'm missing anybody when I get to the end. Nadine Bridges, we also have Sheila Davis, Tammy Golden, Indira Gujral, Megan Hatton, Kate Haywood, and Kate is with the County Attorney's Office. I think you all know her. Rita Mangan, Susan Motika, Lexi Nolan, and I believe that's it. Did I miss anybody else that's staff that's on the phone? That's it.
Okay, well, we do have a quorum, and so the regular board meeting of the Boulder County Board of Health has been called to order at the discretion of Public Health Director Jeff Zayak. Notice of this meeting was posted on the Board of Health's website as required by law and included the teleconference phone number and conference ID so members of the public could participate in the meeting. Due to the current COVID-19 pandemic and the need for social distancing and compliance with the current public health order, this meeting is being held telephonically as authorized by the Boulder County Board of Health bylaws. Okay, so first item on the agenda is public comments, and these public comments are for any unscheduled items on the agenda. Do we have any public comment? Okay, I'm not hearing anybody. So seeing that there are no public comments, we'll move on to item 2, the approval of the Board of Health minutes, which include the October 7th special meeting minutes and the October 12th regular meeting minutes. Any call outs on those by board members? If not, motion to approve, please.
Greg, this is Tammy. I just want to let you know that Jorge's on now.
Jorge, could you please introduce yourself?
Yeah, this is Jorge Santiago, board member.
Okay, thanks, Jorge.
This is Morgan. I move to approve the October 7th special meeting minutes as well as the October 12th regular meeting minutes.
This is Brooke. I second.
Okay, all in favor?
Aye.
Aye.
Okay. Now, item 3 on the agenda, which is Resolution 2020-04, a joint resolution with the Boulder County Board of County Commissioners declaring structural racism as a public health crisis in Boulder County.
Greg, thank you. And I just want to do a really brief and quick introduction here. I'm going to turn this pretty quickly over to Sheila Davis, who is our health equity coordinator. As you all know, Sheila has been doing an extraordinary job managing, gathering feedback, and coordinating what you see in front of you today. This is a historical moment for us in Boulder County Public Health. And even though the commissioners are not on the phone with us tonight, I want to tell you all how much I appreciate Sheila's effort to get this in front of us, along with a whole host of folks who have been providing feedback. And I'm most appreciative of our Boulder County commissioners for being willing to tackle this as a county. As you know, we delayed this a few months back, and the reason that we delayed it because we knew we would be much stronger as a county moving this forward, and that it was necessary as a county to move this forward together, and that's where we are tonight. So I'm going to quickly turn it over to Sheila, but I want you to know how much I appreciate all the work to get us here, because again, this is truly a historical moment for Boulder County Public Health and the county commissioners. Sheila.
Thank you. Thank you for providing an opportunity for me to speak to you this evening. It's an exciting time to be working for a county government where the opportunity to advance justice and equity is within our grasp. By way of introduction, I would like to summarize our journey to this point. I will begin by reading the BCPH Health Equity Coordinating Committee, or HEC, vision statement. Boulder County Public Health is an inclusive, racially and socially just agency that centers the voices of marginalized people and embeds equity at all levels of leadership and agency decision-making. In partnership with our community, we work to provide equitable access to a healthy life for all people in Boulder County, with particular focus on historically marginalized communities. BCPH and other Boulder County agencies such as Community Services and Housing HHS contribute to this vision through the programs and services that we all provide. The election of Marta Lokeman, the first Latina county commissioner in Boulder County, is a further testament to this mission. However, realizing the HEC vision statement and achieving the county's strategic priorities of equity and justice will require more work on our part. Those of us in public health are trained to look into the hidden corners, the shadows of society. To that end, BCPH began having these discussions about root causes of racial and ethnic health disparities about a decade ago. These root causes have everything to do with structural racism, that is, systems in which institutional policies, procedures, practices, cultural representations, and other norms work in reinforcing ways to perpetuate racial group inequities. You don't need a rogue actor to set structural racism in motion. It's part of the fabric of this country. The resolution cites evidence of structural racism in many institutions, including law enforcement, education, healthcare, and child welfare at the national, state, and local levels. The BCPH discussions ultimately resulted in the formation of a health equity transition team in 2016, which became the Health Equity Coordinating Committee in 2018. The high-level charge of the HEC is to dismantle structural racism within the agency. Parallel efforts were occurring at the county level with the rollout of the Cultural Responsiveness and Inclusion, or CRE roadmap in 2016, which are set forth in the resolution. Milestones to date include hiring of a diversity, equity, and inclusion manager at the county level, courageous conversations about race or CCAR trainings and ongoing discussions for all Boulder County employees, advanced training in the CCAR protocol for Boulder County employees, implementation of the cultural responsiveness and inclusion work groups in Boulder County agencies, application of a racial equity lens using the Government Alliance on Race and Equity, or GARE toolkit, to the work of the COVID-19 Forward Together Safely teams, participation in GARE trainings and membership in the GARE network, administration of the GARE Racial Equity Survey in Boulder County this year, and finally, the launch of the COVID-19 Forward Together Safely Community Task Force. Boulder County recognizes that it cannot create opportunities for all Boulder County residents to live healthy and fulfilling lives without the cooperation, coordination, and alignment of all Boulder County agencies and offices and local municipal governments. This will require the development and implementation of the Boulder County Office of Transformational Racial Equity and Justice, a structure that supports and drives the ongoing and evolving work of a transformational racially equitable, multiracial, and anti-racist organization. County governments have a unique leadership role to play in dismantling structural racism in their respective jurisdictions that neither the private sector nor academia can fulfill. Boulder County and BCPH are at a critical juncture. We have a fertile opportunity to achieve a more just, inclusive, and equitable community. Thank you for your support and leadership on this venture. And I want to thank all that contributed to the resolution, including members of the management team, the Health Equity Coordinating Committee, the Cultural Responsiveness and Inclusion Advisory Committee, and a whole host of others. So at this time, I would love to address any questions or comments or concerns that you might have.
Hi, Sheila. This is Greg. So, in reading the resolution, I'm just curious, like, I know Jeff mentioned that we delayed this announcement or this action for several months. And I'm just wondering, like, how much does the disparate impacts of COVID, the overall COVID response, what we're seeing, I mean, it seems like that's a big driver for introducing this now, but clearly it's not just related to COVID, because going back 4 years now is when we announced, you know, the kind of the beginning of that path to getting to this point.
So COVID certainly did contributed to the time that we selected to make this public. We had originally planned to present this in March, and then we had to deal with the response. But I feel that it has strengthened the resolution because COVID has revealed the deep fissures along racial lines. And this resolution reflects a collaborative process was used. This, as I said, reflected the input of so many in the county, and I think that the resolution is stronger for it.
Thank you.
Thanks, Sheila, for, oh, I'm sorry. Did I cut somebody else off?
Nope, go ahead.
Okay. Thank you, I should say, Dr. Davis, for your work on, and leadership on this. I think it's really exciting for the county. So thank you for that. And when is that new office going to be created? When is that going to go into effect? What's the plan for that?
So a companion resolution is being drafted as I speak that goes into the detail, the mission, vision of the office, the organizational structure of the office, the goals of the office. And so I anticipate that resolution will be presented in the next few months. And then, the hard work of actually launching the office would begin with the onboarding of the new commissioners, and they would have a role and a say in how in the rollout of this office. So I'm just projecting, over the next 6 months is when all of this work we will actually set this in motion.
And the office will be under the county's structure, and public health will be interacting with that. Is that kind of what the general ideas? It sounds like some of the details are yet to be worked out.
Yeah, so the office would be housed within the county commissioners, and all of the agencies would feed into the office. Mm-hmm. And how that looks right now, we don't know. But it would that would be the structure of it.
Looking at the final resolutions at the end, most of the resolve that are internal, and the external facing one seems to be the COVID-19 FTS Community Task Force. And I couldn't really find much more information on that or the racial equity team within that group. I was just curious if you could maybe expand on some of the external outreach that comes with the resolution, if that makes sense.
Yes, I'd love to. So the racial equity team is one of the Forward Together Safely teams. And the community task force, which was launched in September, represents our priority populations, the unhoused, incarcerated, our new Americans, various communities of color, mountain communities, people over 65, people on the ability spectrum. And they have their finger on the pulse of the priority populations. And so they have been bringing to the Forward Together Safely effort many of the pain points around COVID that our priority populations have experienced. And in turn, we are asking of them questions that we need. We need all sorts of information as we recover and respond to the pandemic. And so it's this bidirectional flow of information. And the community task force meet on a monthly basis.
Thank you. Can I ask another question? Aside from the FTS task force, what else do you see coming in as external effects from this resolution? Or should it really remain primarily internal with the trainings and following the CRI map?
The CRI map, right. So the office will certainly have an external face. There will be a community engagement component in addition to the community task force. And we also envision this office having an advocacy arm, which might include, movers and shakers in the county, equity advocates, as well as some people within government. Does that address the question?
Yep, it does. Thank you.
Sure.
Any other questions from the board members? Thank you again, Sheila, for your hard work. Remind me again, how long have you been with the county? 2 years, year and a half?
No, it's been a little over a year.
Okay, all right. Well,
Hey,
that's
Greg, can
great
I
work.
add just a couple comments to
Sure,
what
Jeff.
Sheila added? I just want to illustrate a couple things that I think are really important as we're moving forward as well. So from an internal perspective, I think most board members know that the county has been, so we have a HEC group in public health. There's several other groups in other departments that have been working on some of the internal focus that you see there. So bringing this office together at this point to both help coordinate and organize that work in a much more strategic way, as well as I think I feel pretty confident that I can say this on behalf of the commissioners based on the conversations I've had with them. But the importance of capitalizing on the external is especially important. And if you just look at the examples of some of the things that have happened just from public health in the last year, like the mobile home work that happened and the support of community members who organized and then made change in their own communities, and the importance of that is how much of this work needs to evolve moving forward. So I know that we are at both a pivotal time, and we've also got, as Sheila mentioned, there is other movers and shakers, and there are other governments and municipalities right now that are also advancing this work. So the timing is really critical and important. And again, I feel like this is a historic moment for us because we have the ability to really move some of this work forward. I'm not sure if everybody saw, but the city and county of Denver, or maybe it was Denver Department of Public Health and Environment. Sorry, I should use the right language. Also passed a similar resolution today. Jefferson County has passed a similar resolution. The state has also passed a statement or a resolution relative to this as well. So it just is, we're at a very critical time. And I think this step forward is going to help us as an entire county be able to leverage and support the work of where others are as well. So I just feel, again, so proud and so enthused about where we are right now. And thanks again to Sheila and the so many folks who had worked on getting us to this point.
Thanks, Jeff. Okay, any discussion from board members? And pending that, then motion to adopt the resolution.
Move to adopt. This is Landry Fagan. I move to adopt.
This is Jorge. I second.
Tammy, do we need to actually spell out what we're approving?
You may want to have them read at least the title into the motion. So resolution 2020-04, and then just state that it's the joint, they can read it from the agenda title.
Okay. If we could repeat that, I would appreciate it. Thank you.
I don't have it right in front of me because I'm on my phone. Can someone else read it?
It's the resolution 2020-04 joint resolution with the Boulder County Board of County Commissioners declaring structural racism as a public health crisis in Boulder County.
So thank you, Morgan. And we had a motion and a second on that. I just wanted to make sure that was in the record. So all in favor?
Aye.
Aye.
Okay. Ayes have it. Motion carries. Thank you again, Sheila, and for all your hard work, and Jeff, and really everybody across the county. Okay, so let's see. We have our next agenda item, and that is item 4, which is resolution 2020-05, adopting the 2020 Boulder County Public Health amended budget.
And I don't see Marielle on the phone, so my guess is, Megan, are you taking this?
Yeah, Marielle figured this was a short one, and she had some childcare conflicts. So I'll just go over it quickly. It shouldn't take too long with the board. So the revised budget outline in resolution 2020-05 includes an increase in revenue of approximately $1.1 million. This is coming from our CARES Act, mainly in support of our agency's COVID-19 response and recovery efforts, supported through the county. The budget amendment that's been approved, or excuse me, that we're requesting approval for, is from a $18 million to $19.6 million, a net increase of 1.58. The overall changes in our fund balance are a total of, let's see how, sorry, I'm not sure if I read that one right. The overall changes will not change the unrestricted fund balance of 2.3 million and will result in a reserve fund balance of 12.8 for our 2020 expenditures. Just one note with that, that is a pretty high reserve fund balance, but we have not taken into consideration any increases in salaries for the next year, because we weren't sure when we completed this whether or not that was going to go through. I will tell the board that there is a meeting with the commissioners tomorrow, and it does sound as if at minimum, a cost of living increase is now on the table. So that reserve balance will start to be eaten up by that. Pending your questions, we request approval of the amendment.
Any discussion from the board or any questions?
No, I mean, I would just say it's great that the county has made this funding available, and I'm sure that there are a lot of need for it. So that's great. And I'm glad that they are considering cost of living increases for staff, especially given how hard everyone's been working.
Yeah, I think it's big.
Okay, if there are no additional comments or questions, then can I hear a motion?
This is Morgan. I move to adopt the resolution 2020-05, the BCPH amended budget.
This is Brooke, I second.
Motion and a second. All in favor?
Aye.
Aye.
Okay, that motion carries.
Thank you.
Megan, for your time.
And Marielle she'll probably be back next month to provide the 2021 budget for you all. So we will see you then.
Okay, great. Thanks. And now it looks like it's our favorite time of the month on that update on the current COVID-19 pandemic, item 5 on the agenda.
Yes, I'm going to share my screen. Thank you, Greg. And bear with me for a second. Let me close this other one. I've had trouble with this today, so bear with me. I'm going to close my other PDF, and that one should be open. Let's try that again. There it is. Let me know when you can see that.
We're good.
Okay. So what I want to do today is just go over the latest update with you all. These are pretty sobering slides, so I'm going to give you that heads up before we get into this. And if you've been tracking our website or the state's website, or even watching the newspaper, you'll see that our numbers are in a similar place to others in the state, and we've got some challenging weeks ahead of us. And that's really what I'm going to focus on today, is what some of those challenges are, what our next steps are, and want to make sure everyone's aware of what that looks like. So let me minimize this. This just demonstrates where we are as of today, our status in Boulder County. We are categorized in level orange. The state moved us on the dial last week, so that has been effective since last Friday. And already since we've moved, that we are already above and into our stay-at-home level for our incidence rate. So you can see our incidence rate is at 437.1 per 100,000. This is very consistent with what you're going to see in the other slides I'm going to show you. We have incidence rates across the state that are rising extremely rapidly. So we're jumping fairly large percentages pretty quickly from day to day, and I'll show you why that's happening. Our second indicator is our average positivity rate over 2 weeks, which is 6.8%. And there's 9 days of declining or stable hospitalizations in Boulder County, but this is a little bit misrepresentative, or I won't say misrepresentative. It doesn't paint an accurate picture, and I'm going to talk a little bit more about why that is and the challenge that we have from this specific measure at the state versus what we actually see in Boulder County. I just wanted to show you this graphic because it's pretty illustrative. There's actually a time graphic that I can share with you after the meeting that goes through a time lapse. It's an animated graphic that shows how this has changed and how quickly it's changed, especially over the last 2 weeks. But I haven't tallied up all the red, but if you're seeing red on that map, it means that we have counties that are exceeding indicators in stay-at-home for incidents. That's probably about 50% or more of the state right now, and it's certainly the most populous areas. So if you look at population, the majority of our population is now in a stay-at-home level in terms of incidence rate on the chart itself. At this point, I don't believe anybody has yet moved to stay at home, but that is part of the challenge that you'll hear from me in a second here. This is the state numbers reported across the state. You can see the significance of this peak comparative to our previous peaks and where we are now. This is the Metro Denver area, 7-day moving average of new cases. And you can see, again, as challenging as it felt like we were with the University of Colorado right here, we have incident rates across the metro that are significantly higher than that at this point. And we are approaching a level that is close to CU. So this is the challenge that we're facing. You can see the steepness of this climb and how quickly these cases are rising. This is the CU graph that I've showed you before, able to effectively really do control work to help keep CU cases down. That is definitely because of a really strong partnership between the City of Boulder, the University of Colorado, BCPH, and others that have really helped to make sure that we have a strong process in place to follow up when we're seeing parties on the Hill. As you can see, we're starting to see some increasing cases associated with CU, and I believe you all heard that CU is now moving remote starting next week, so they're ahead of the schedule, and they've done that purposely to try to help facilitate testing folks that need to travel and making sure that people can travel safely without exposing others. They do have quarantine spaces available for people that do test positive to both isolate and quarantine if they need to here locally. This illustrates that 18 to 22-year-old peak that I showed you in the past. You can see that it's come down to the base level. This base level is the challenge for us. I'm going to show you this base level broken out on the next graph. And this is really the illustration of the challenge for us. This is all age groups. I'm sorry that popped up. Let's see if it'll pop back down. This is all age groups across the county. And you can see that in every single one of these age groups, we've got significantly steep increasing rates for 2-week incidents. And this has been a significant challenge. And when we get to this point in a community, it makes it really difficult to do a specific and targeted strategy like we did with CU for this outbreak here. We were able to target the 18 to 22-year-olds. We knew where the majority of that was coming from. We're now in a scenario where we have spread across the majority of the community. And we know that people are fatigued with COVID. They're kind of at the end of the rope, like I'm sure each of us are. And they are relaxing their social distancing, they're relaxing masking, and they're getting together in groups and gathering. And we know that's causing this spread. If you look at the historical data, I'm not going to go back there over the slides, and it's kind of hard to see it here, but we can see this pattern, especially as we look at holidays. So when you look at July 4th, you look at Labor Day, we've seen spikes. We know that, again, the spread of those cases is coming in places where people are gathering, and they're just not paying as close attention to the social distancing, the masking, the hand washing as they should be, and that is causing increased cases. When we lose control of those cases and it starts to become community-wide is when you have to have community-wide approaches to try to get that back in check. So as an example, we are at a statewide level, we're only about able to get to about a third between a third and a half of the cases that are identified as positive, both in terms of case investigation and contact tracing. So there's a significant capacity issue now at a statewide level because there's so many cases and the incidence is so high across most of the state, as you saw on that map. This is where the cases are coming from in Boulder County. So you can see that the majority of our cases are coming from Longmont in the light blue, City of Boulder in the dark blue, and then a combination of Lafayette, Louisville, Superior, and unincorporated and other municipal areas. Those together don't equal up to what the City of Boulder and City of Longmont, which has the largest populations, is producing in terms of cases. This is a continued, and I think this goes right back to the reason, one of the reasons why we just put that resolution forward. If you look at the data here, our Hispanic population is 13.8% of our population, but our COVID-19 cases are 30.7% in our Hispanic population, and our hospitalizations are 43% in this population. Clearly here we have equities that we need to turn around. And if you look over here, you can see that's inverse for the most part. So we know that this is a continued driving force. We know that many of these folks are on the front line essential service workers, and we really need to focus on shifting this. At this point, what I would like to do is just turn it over to Sheila Davis briefly to talk about some of the things that are happening in this space and the work that we're doing to try to build resource for this community and to try to turn this graph around. Sheila?
Hey, Jeff, can I just, before Sheila begins, can I just ask, the data has been pretty consistent in this area. Has it moved significantly in one direction or another? I'm trying to remember what it was like, say, 2 months ago in terms of our Latinx cases.
It has, and I would call on anybody else who knows this for sure. The trend that I have generally seen is that it's actually gotten worse. So at one point, as an example, in Longmont, we were up to 54% of the total caseloads were in our Latinx population. We're aware of there was outbreaks that were in areas where we had mobile home parks, as an example, and we know that when we have spread in the community, that people aren't comfortable in this community getting tested. They aren't necessarily comfortable seeking support from a provider. They may not have a provider. And as a result, a lot of these folks, as I had mentioned, are critical service workers. And when you test and tell somebody that's a critical service worker that they have to stay home and quarantine, it can mean the difference between them being able to support their families or not. So we've got a whole host of things happening in this population that we really need to focus on. But in general, it's gone up and down, but I've seen it overall still be a significant area of challenge for us. And I'll just stop there and see if Indira or Sheila or anybody else on the call has more specifics relative to that than what I just said.
Well, I just wanted to add that the agency is now centering priority populations in its work. Lexi and Susan are drafting a strategic plan to address the disparate impact COVID is having on our priority populations. One of the objectives of this plan, short term, is to prevent the spread of COVID in the Latinx community through culturally responsive prevention, rapid testing, case investigations, and contact tracing and quarantine. We have hired Nick Robles. He is our bilingual, bicultural COVID resource coordinator. He's working in partnership with Guillermo Estrada Rivera, who directs, supports our cultural brokers. We have, if I'm not mistaken, we have a pop-up testing site now in the Country Meadows neighborhood. If Indira, if you have other information to add to this, I'd also want to say that the strategic plan that is in progress is based on the recommendations of Resilience for All that was published in 2018. It sort of begins where that report takes off.
Yeah, I think everybody covered everything. I think the disparities have been persistent and definitely highlight all the inequities that we see in our communities. And we see the populations that are disproportionately impacted. I would say that the work that Sheila's doing, the work that the agency is doing, we're about to make an important pivot because traditional epidemiology can't be applied universally just to everyone. We have to take in culture and cultural context. And so I look forward to seeing this new plan that will be more culturally responsive and allow us to make the pivot and address these disparities.
All right, I will keep going. Thank you. Thank you both. All right, so this next slide is our hospitalizations. Just a quick reminder, at the highest point over here, we were at 68 in the previous high point in the outbreak for hospitalizations. Throughout the summer, for the most part, we've stayed really low, but we are back up. We're at 78 now, but we were at, I believe it was 80. I can't remember the exact high point, but it was close to 80. It's above where we were in the previous part of this outbreak. Our hospitals, we are meeting with them weekly, and what we are hearing from our hospitals is that they are the biggest challenge for them at this point is actually staffing. They're having lots of concerns around staffing. The hospital census itself is up as well. So in addition to what you're seeing for these COVID positive hospitalizations, the hospital census has been up in general. So there's a lot of people that are in the hospital. So when you look at our medical surge bed availability as an example throughout the summer, you'd even see that some of that med surge availability was in use, and that's because of other hospitalizations that are in place. What the hospitals are telling us is that they want to be able to make the call themselves around when they need to stop doing elective surgeries because from a capacity standpoint, with exception of some challenges we're now starting to hear relative to ICU vents that are in use, that they can create capacity for med surge availability by going to stopping elective surgeries, but they want to be able to, and they feel like, and I agree, that they have the capacity to manage those things themselves. They know best when to make that call. They're tracking this very closely. In addition, I would say that the state has also, they still have, I don't remember the total number of sites, I know I should, maybe 4 sites at a statewide level, I'm just not positive, alternate care facilities that can be used for surge. The one that is just north of us at St. St. Joe's, maybe somebody on the phone can make sure I'm saying the right name, but thank you, appreciate that. That one is actually can be used for if we have long-term care facility discharge issues associated with hospitalizations. That hospital can be used for that. But we do have alternate care facilities around the metro area. I think part of the challenges is being able to both, the same thing that we heard with our hospitals, that staffing these things is becoming a little bit more of a problem. Being able to staff those alternative care facilities, they do have some contracts, but being able to stand those up and staff them in a quick manner is going to be maybe a little bit of a challenge. But our hospitals are tracking all of these things really closely. This is the state hospitalization, similar picture, obviously, that you're seeing to local hospitalizations. And we can see and we know that that's happening. Again, this illustrates the point of we really need to pay attention to how we're gonna control this outbreak at this point, because we're short on the ability to contact, trace, and to do case investigations. Therefore, we're gonna have to look at more population level approaches. This is the next to the last slide. I wanted to talk about this because This has been an important conversation for weeks now, and this conversation is just amping up even more. So the Colorado Department of Public Health and Environment published a document that I just sent to all of you as board members, so you have access to it. The state has published this on their website today. I've shared this with the district. I presented to Boulder Valley School District staff and teachers this morning and highlighted this as well. But the conversation around schools specifically has been focused on risk and operationalizing schools and being able to support that. And from a risk standpoint, and I think the state did a good job with this document, really highlighting where risk and what risk looks like from a statewide perspective based on the total number of kids that are in schools and enrolled in schools. And they did a great job of illustrating that lower point, which is that K through 5 is the lowest risk. And they're also the students that need to be in person more than anybody else because of the fact of where they are in their learning, because of the fact that we have parents who are leaving the workforce now. My guess is that's not a surprise to anybody on this call that's listening in. We know we're losing women specifically and mothers from the workforce because of some of the requirements when schools close and how they have to deal with supporting their child. And we have that same issue in our own organization as well as in the county. So the focus has really been on trying to keep those kids K through 5 in school, and then looking at more of a hybrid approach for 6 through 8 and 9 through 12. There has been a lot of conversation around what's really driving the outbreaks. And when you look at our 0 to 17-year-old age group, those two lines that were on that earlier graph, what we are seeing is what is referenced here, which is most of what's happening in schools is being brought in from outside of schools. Because we are seeing schools as a place of controlled risk. So let me give you a specific example. Schools, they increase ventilation significantly to make sure they have adequate ventilation in each building. The kids are in a controlled learning environment where they have controlled activity during the day. They're in classes, they're required to wear masks. The schools are social distancing to the maximum extent that they possibly can. They have cleaning. There's a whole host of best practice controls that occur in the schools. And that is part of the reason why CDPHE and others are seeing that there is less spread. In addition to the fact that kids, especially in the K through 5 age group, even though they can become positive, they can spread it to others and they can spread it to adults. The school sites in those areas are not a large source of spread. And we saw the same thing with CU. So when we looked at the University of Colorado, we saw very little spread in the classrooms themselves. The majority of the spread we knew was happening outside of the classroom. It was happening associated with those gatherings, with the parties, with kids getting together, not masking, not social distancing. And when we take kids out of school, we do the same thing with those kids. We know examples, and if you all were looking at the paper a few days ago, you saw an example where a parent who had a child who tested positive sent that child to a party, rented a party bus. We have stories of parents that we hear that are just not taking it seriously. So when a kid is symptomatic or they've tested positive, they are just, for whatever reason, not taking the virus seriously, and it's ending up spreading to others. So it really is a community approach in order not only to protect our oldest folks who we know are dying from this disease, but also to protect the folks who end up in the hospital, to protect our economy, to support our businesses, to protect our social, emotional, and mental health. All comes down to everybody working together, and that's really what's going to drive a change in this virus in the long run. And that's pretty much what some of these emphasis points are. You've already heard me talk about most of these. I just want to hit on a couple. This is the first one. This estimated 1 in 100 people in Colorado are now infectious. So in the middle of last week, that was about 1 in 145. If we were looking like 6-8 weeks ago, that was around 1 in 300, 400. And in the middle of the summer, when our numbers were some of the lowest, it was around 1 in 800. So we have a lot more virus circulating in our community right now, which means that it's harder for us to control it. And you've heard me talk about social distancing before, which now they're calling transmission control. But the amount of social distancing that we need to control this amount of virus in our community is much higher than it would have been 3 or 4 months ago when we had 1 in 800 people in our community who were infectious. So again, it leads us to needing to identify what you see under that incidence rate bullet, which is we have to submit a mitigation plan to CDPHE. We will have to demonstrate to them what actions we're taking to try to stay out of stay at home, which, as I showed you, our incident rate is in right now. So the reason that we've asked for the meeting, and again, I want to thank you as board members for being flexible at the last minute to come together for an emergency board meeting, is to bring you our mitigation plan, but specifically the orders that we're considering moving forward and we want to bring to you. We've worked with the Metro Denver Partnership for Health across the region, and we've identified strategies that we want to try to implement together to the maximum extent possible, because we know we're sharing populations. It helps us when we can be as consistent as possible in how we approach things. So we will be bringing you some order to consider when we meet on Thursday morning, and we'll talk about how that fits into our mitigation plan when we present that. And I'll also talk about the time frame and what CDPHE's time frame looks like, and how they treated us in the last time frame versus how they might treat us in this time frame, so you know what those options look like and some of the contingencies around that. So that's a lot of info, not great info, as you all I'm sure are aware, but I'll stop there and see if there's questions.
So Jeff, talking about the school ages, are we potentially looking at an order similar to what we had for CU, but for 18 and under?
No, we're not. And the reason being is because those rates now are all lumped. I'm going to go back to that slide just to illustrate the importance of this. So the reason that we could do this with the 18 to 22-year-olds is because, I'm going to go back one more. So if you look at all of these here, they're lumped together. This is spread that's happening throughout this population. When we were able to go after the 18 to 22-year-olds with strategies, it's because this was so clearly out of alignment with everything else that was happening. We knew what we needed to do to control this and get the transmission reduced. At this point, our populations are all mixed now. So our 0 to 17, which 0 to 9 and 10 to 17, which is our school age population. Again, we know that the majority of the spread that's associated with those kids is actually happening not within the school. So it's not a school age spread, but it's a school site spread. It's happening more in the community and being brought into the school. So we think that having schools in place is an actual protective factor for those kids. So we're looking at more generalized orders that would look at some of the highest risks in the community, but that would not be one of them, because we think we already have a strategy that will help protect kids.
So you don't think then that we're going to look at anything that would specifically inhibit school-age children from mixing outside of school, except under a mass order?
That's correct. Yeah, and we have. I don't want to put things finalized forward yet because we haven't finalized everything. But we are looking at. For instance, we're looking at restrictions that would lower the amount of gatherings that could occur. And because we know that those are the areas where we're seeing spread, we already have a strong order in place with the governor's new orders from just a couple weeks ago. So the 10-person, no more than 2 family, but we know that people aren't following that. And I think this is part of when we talk to you about the order that we're going to bring forward to you, and it is probably going to include 3 or 4 components. I think our challenge, even with that order, will be to see if we can get significant reductions If people aren't going to follow this, we cannot be in every place all the time. So we're going to need a pretty major outreach campaign that happens with this to try to get the spread changed. Otherwise, we would be headed towards a stay-at-home level at some point again. And that's what we want to avoid. That's what others want to avoid. But it does come down to people's ability to follow the orders that are in place, and for us to look at other tweaks to orders that would further reduce where we think the spread is occurring.
Thank you.
Hey, Jeff, this is Greg. So when you're in the red for one category, right, there's 3 categories for, say, stay at home. And just with the number of cases per 100,000, clearly we're in the red. What is there a minimum number that has to be hit, like 2 out of 3?
No, there is. If you have one indicator that's out of your current, wherever you're currently categorized, that then triggers a conversation with CDPHE and the requirements of a mitigation plan to demonstrate how you're going to bring that measure back into play. So it's not like you have to have 2 out of 3 or 3 out of 3. Okay. Any one indicator can push you into the requirement for the mitigation plan.
Hey, Jeff.
Yeah.
This is Morgan. So thinking about, I know that like we're required to create a mitigation plan and submit that to CDPHE. Does BCPH have a plan that it is able to share with the broader community so that one that we can communicate with the broader community about, this is the plan, not just for, the next several weeks, how do we get out of this red zone, but sort of this is our longer term plan that also lays out who our priority populations are and what the strategies and resources we're putting towards those priority populations, just so that we can be really clear with the public about, this is how we get out of where we are right now, but this is also how we're going to manage this pandemic for the next several months going forward.
Yeah, Lexi, do you want to talk a little bit about the COVID plan that you're working on, and the priority populations plan that you just mentioned, Morgan, is in place now, but we can pull those things together. Every time, obviously, we do a mitigation plan or a surge plan, we make that available on our website. But Lexi, do you want to talk a little bit about the COVID plan specifically?
Sure. So thanks, Jeff. The priority populations plan is embedded in the longer term COVID strategy that we're developing. So they're kind of combined. And what we're really trying to do is be very careful about thinking about, what are the resources that we have? How do we use them most effectively? How do we collaborate and coordinate with other agencies and actors in the community, and really be careful about defining goals and objectives that are flexible but kind of keep us centered and focused. And I think it would be a great idea when we get another week or 2 down the road, or a little bit further down the road, to be able to summarize some of the high points in that plan for the community, so that they have a much better understanding of what the agency's doing, where we're really trying to make inroads, some of the efforts that we're making to really protect particularly the elderly and the medically vulnerable in this stage when the surge is really bad, but then how we flexibly pivot out of that to also address broader community needs. I think it'd be great to have a summary for the public, so that they have a better sense of that and how that work is happening, not just within BCPH, but in collaboration with our partners across the county.
Yeah, that's great, Lexi. Thank you for that, because I do think that in reading the paper every day, which I do, we're competing with other narratives that are out there that, either are like Chuck Libby's piece, you're either putting out information on a narrative that says we don't need to worry about this and we're overreacting, or there's, other pieces that are running in the paper that are speculating what should be done, but it would be great to be able to respond to, thanks for that input, and here's what the plan looks like, and here's where we are in that plan, and here's where our priorities are, and just that, and in whatever ways the board can also help in promoting that narrative and that information so that the community feels informed and also feels like they understand, how they fit into that plan.
Hey, Morgan, the one other thing I would mention to you is that we have our Protect Our Neighbor requirements on our website. That's ultimately the goals that we have to get to that level of environment where we feel like it would be most beneficial until we get to a vaccine. And there's a whole host of things. So as you know, and we've been reporting to you, one of the components of that, there's 8 different measures. One of the measures is to build up our staff to make sure that we can respond to a certain number of case investigations and contact tracing. And when we get into a situation like this, where we have so many cases and it's happening in so many places across the state, and we're not applying the tools the way that we could have as a statewide approach, then we get behind this virus and it gets really difficult to control. So we could talk more about that, but that's been a big challenge. We obviously, and I'm going to illustrate this point again because I think it's really important. So when we were in the summertime, before we had CU students come back to school, we were on a path to get to Protect Our Neighbor. We had the right measures in place. We were building toward those measures. We had a CU outbreak that spiked us and stopped us from getting there. By the time we came down from that spike, we had significantly increasing cases across the state. And once that happens and you lose control of that, it puts everybody in the same boat. So it's hard for anybody to get to Protect Our Neighbor when that happens. And we've missed the availability to use tools to stop that from occurring at a statewide level, which is what it takes because we know we have people that travel across counties. And if we don't have statewide approaches that are consistent, then we know we're not going to be able to control this. So I just want to add that to this conversation because that's an important point.
Hey, Jeff, this is Greg. So, I mean, at some point with the cases rising like they are, right? I mean, at best, you can hope to do just the case investigation, which is for the person who actually tests positive, right? The resources beyond that to then contact trace their contacts, I mean, it's impossible. I mean, at certain numbers, I mean, certainly with the increase that we're seeing, that's a huge worry. If all you can do is just try to stay on top of case investigations, but little contact tracing. So, man, it's worrying for sure. And I mean, the one thing that the models seem to have been consistent with all along is the seasonality, right? It's getting colder. People are spending more time indoors and probably still gathering, unfortunately. And when we started this in March, we were leaving winter, entering spring, and now we're going, we're in fall, headed toward winter, and it's just, I mean, the models are not good.
Yeah, and I want to say this again because I think it's so important, and we've reiterated this to the state that we could have avoided being there. We were building a plan that we knew would work, but we've missed the opportunity to leverage the tools that were put in place. And that has to happen at a statewide level. It can't just happen at a local level. Susan knows this because she's been in all these meetings with me at a statewide level. We have 2 times a week conversations about this with the state health department and with the governor's office. And we have missed the ability to leverage the tools that we had available to us to prevent where we are right now from happening. And now that we are in this place, you're exactly right. For us to be able to get control of where we are now, based on those case rates, not just in Boulder County, but across the majority of the state, it's going to take a lot more work to get a handle on that and to get us back to where we could handle the cases, where we can to get to a Protect Our Neighbor level. So we've missed that leverage point.
This is Brooke. This is kind of a follow-up on Morgan talking about communication. I think you all have done an excellent job with communication, especially with the Thursday updates every week. However, what I'm seeing is that people know the rules and are explicitly going against them. And so it goes into what you were saying, it's burnout and people aren't following what we're doing. And you had mentioned last time that we would try to avoid stay at home through the state's education program. If people are just ignoring what's being communicated to them, do you think then that we're really heading at stay at home, or are there some novel options that we haven't tried yet? And maybe we're going to talk about these on Thursday.
No, I wish we had novel options, Brooke. I think it's a great point. And I think what you're saying is very accurate. We're in a place now where being able to be really creative about how we get the community to support these kinds of things when we have such fast and increasing rates. And I'm going to give you a specific example. If you look at Northeastern County, I think it's Sedgwick, I can't remember exactly, the rate's been over 1,000 in that county for more than 3 weeks. And the challenge that we have at this point is really finding a way to stop this and then work with the community on how do we actually bridge the next 6-8 months until there was positive news today on a vaccine. We're always, of course, listening and watching and wanting to make sure that the vaccine is effective, that it's well tested, that the safety data has come back, that it's been reviewed. And I know that process is occurring. But in our long-term goal is to get to a place where we actually have a vaccine, where we can build herd immunity in our community. That's going to take some time even after the vaccine gets here. And what we need to try to find a way to do is to bridge this time between now and then and do that in a way that can help our community engage in a way that does help them support this. What we know can happen is we can have a lot of people who are willing to follow this. But if we have a few big outbreaks associated with people who don't want to follow it, that can get out of hand pretty quickly, as we saw with the university. And when that happens across all of our age groups, it becomes that much more of a challenge. So I think you're right on track. I think it is going to be a significant challenge for us as an entire state to be able to effectively bridge that. And we have to keep thinking about it with the limited amount of resources that we have to, as you heard, we don't even have enough resources right now to be able to respond on a contact tracing perspective. We're having to send letters to people. So we're in a tough spot right now.
Can I ask more about the resources? So like what can we do? How can we support? How can the board support you, Jeff, and your team on getting the resources that you need? And I understand, like hiring is challenging, and not even that we could hire enough potentially to deal with where we are right now. But I'm just thinking about looking at the resources available to BCPH. Do we have the resources that we need? Are there other places that we can look to increase resources? Are we considering, shifting resources internally from within the organization to ensure that, the COVID response has what it needs right now?
Morgan, we have done each of those things, I think. So we've shifted internal resources and have done so throughout this. So we've got people that are on contact investigations that have been shifted from their work. As an example, just one example, we've brought in 9 new staff from community services through workforce just recently. We have maximized the use of our ELC funds and the DOLA funds, including county funds, to bring resources in. But I do want to just again emphasize, so when we have the type of situation that we have right now, we could hire another 20 staff, and we're probably not going to get to the point where we need to be. I want to go back to what Brooke said, because I think that we're making our best effort to try to control this spread, but it's probably going to take us to get to stay at home to be able to really get a handle on the way the spread is occurring right now. Again, if you look at the spread across how many counties that we have, the rate of that spread, the steepness of that curve, it's almost impossible to get ahead of that by just, you can't contact trace your way out of that at this point. And Indira, I would love, I mean, you should offer any insight you have here, because you're in the middle of this with case investigations and contact tracing.
Yeah, I think that Jeff summarized all the different resources we're starting to pull from. And I would just say that it is beyond what like traditionally when you deal with any kind of viral transmission like this, you can do really solid testing, and we're doing that. You can do case investigations and contact tracing and resource management to make sure that people are supported. And I would say that we're just it's beyond our scale to do a normal traditional epi response. And it's going to take a hammer. It's going to take some type of public health approach, like the order approach, in order for us to be successful in bringing it back down. I think the CU surge was a good example of how those orders were executed, and we saw success very quickly. But what happened, though, was that those CU students also were out in the community, and then the transmission occurs in the community. So we're going to have to be very mindful about how we move forward, and our long-term plan has to keep an eye on those that are going to have the highest risk of transmission. And, you know, I think the most complicating factor about this virus is that almost 50% of people are asymptomatic. So people, you know, think that they're okay. They think that they're healthy. There's trust within families, within neighbors. And so we're going to have to get the message out that you just may not know if you haven't been tested, and you really need to reduce your risk across the board. As a community, we have to reduce our risk because it's starting, you know, people are dying. We've had a lot of deaths in long-term care facilities this week, and it's incredibly sad. And we have to do something to reduce the risk across all population ages. And I don't think epidemiology is the way out.
I also would add too that our epi staff has been working really hard to prioritize our priority populations. So Indira, I don't know if you want to just add a couple minutes around what you've done to look at priorities and how, based on the fact that we can't get to all of this, how you've prioritized how to respond.
Yeah, so we have set up our epidemiology team based on the priority populations framework. So we have people working with shelters and people who are unhoused, and working closely with the jail. We also work very closely with ECE, early childhood education, and K through 12. And then our biggest focus is on long-term care facilities, in which we have both epidemiologists doing case investigations for cases, but we also have infection preventionists who are helping each of those facilities across the county be able to manage when they do have a case from an infection control standpoint. So that's our traditional approach. And then we have what we call generalists, or people who are handling cases in the community. And we've been pretty successful with that model, but with this recent surge, we can't keep up with everything. So for the surge, we do have priorities, which include the long-term care, basically as Lexi stated, you know, individuals who are at the highest risk for mortality and morbidity. And so we're really focusing on long-term care facilities. We also focus on our Latinx communities. And then we also are looking at some school age groups as well.
Thanks, Indira.
Yeah, thank you. Thanks, Indira, for that. And thanks, you know, Jeff, for your responses about resources. And I guess I sit here thinking every day about how hard you all are working. And I am thinking about, like, how are we going to sustain this? And I know I've brought this up before, and I just keep coming back to it because we have so much still ahead of us. And so how can the board, again, what can we do to try to support the staff? And, you know, how are we able to, or how are you assessing staff needs, you know, ongoing, and making sure that we are getting folks the resources that they need as best as we can to try to prevent burnout of staff, because this is just, I mean, it's just getting worse and keeps going.
Yeah.
Yeah.
Go ahead. Indira, do you want to add?
Yeah, I was just going to add, thank you, Morgan, for that statement. And I'm going to think about what we need and maybe think about what we can push up. One of the issues that we were having was around staff burnout, and we have started, thanks to Susan and Marcy Campbell, who have started some internal mental health that is supporting staff. And I heard that they had one of their first debriefs today, and it went really extremely well. And I think that that kind of debrief, is creating an opportunity for people to be able to share how they're feeling, because you have to remember the staff aren't just managing, the cases and the contacts, but they're also managing their home environment, kids at home, losing loved ones. We learned about someone losing their grandparent. So, to COVID, and then there's just normal life that happens as well. And so we're trying to create that opportunity so people have the ability to get the mental health that they need through this.
The only other thing I want to add to that is that we, and we'll be coming to you as a board with this as well, but we have made it explicit that we don't expect our staff to be doing 2 jobs. So when we take somebody off of something to work on COVID, we can't expect them, and we have to, as an agency, support that some of that other work is not going to get done and happen. And that'll be one thing that we'll be talking with you about, because we have had to make shifts in the work that we're doing, and we're going to need the board's support, obviously, because we're not accomplishing all the work that we had outlined in our annual plans. This is, we've been on what feels like now, we were hoping would be a sprint, but it feels more like a marathon. And we're going to, and I know you'll support us, but we're going to need the board's support to say and back us in the community, if the community pushes us, to say that we're not going to get some of these other things done. We're not going to be able to come through on all the work that we've promised.
Yeah, Jeff, I think that's a really good point. I mean, it sounds on paper like, oh, well, somebody could do half of their job and they could support COVID half time, right? And the reality is a lot of jobs are not structured that way, right? You need to kind of sink your teeth into it. You need to kind of get caught up on where you're at. And when you're just bouncing back and forth between this type of work, it doesn't work for most people. And then just people's work styles, their personality. There are so many factors that go into setting, unrealistic expectations, I guess, that you can do both things. You can have it all and still be adequate in both. And I think that's one thing I've learned is that, it's one thing to answer, stay caught up on email, but that's very transactional and something that can be done. But project work, coordination, outreach, all that stuff just becomes so hard in this environment.
Yeah, and I look forward to supporting Jeff, you and your team on identifying, what resources need to be shifted over, because I think, I feel very strongly that, you need to be realistic about what you can do and thinking about how do we focus on getting through this pandemic and supporting the staff in the ways that you do. And I'll just plant the seed here, because I also get a little bit nervous about, Jeff, your planned transition, which I know is several months away, but it feels, as a board member who attends meetings once a month, that it's going to be here before we know it. And just thinking about how do we really plan for that transition and continuity in your role to ensure that we don't lose any momentum or all of the wonderful things that are being done. So just thinking about that process coming sooner than any of us are ready for, probably.
I am working on that, and I will bring that to the board as well, so that you can see what that transition plan looks like, so that we are doing everything we can to make this as smooth as possible. And the other thing I would say is, when we come back to you on Thursday, there is a policy issue that you could help with that I haven't yet added to the list, but I hear you offering it, and I think it's really important in terms of how our ability to move forward as a state is going to look or not. and how long we may be in this really difficult position if we don't make certain decisions. So there is, from a policy perspective, some options that you could take, and I'll outline those for the board meeting on Thursday.
And Morgan, just to follow up on that, so there have been conversations that have just started on that transition, and the board will be seeing some information for an upcoming meeting later, probably next week. So just encourage the board, stay flexible, because we need to, we can't wait for these monthly meetings. So you'll see probably an off-cycle meeting, but we need to notice it properly and all that. So just be aware that will likely be happening before Thanksgiving.
Great.
And maybe also in the next meeting or meeting after, if we could maybe talk about the state's vaccine plan. We kind of briefly mentioned it last time, if that would be possible.
Yeah, Indira, does that timing work?
Yes, it does. It's evolving every day, but we are getting a good sense of what the distribution plan is going to look like. And we're identifying what logistic needs we have in terms of planning, and then figuring out what is the LPHA role, or what's the local public health role versus what are community partner roles. And I'm happy to bring that forward in December.
That would be great. Thank you.
So as we wrap this item up, Jeff, we've heard, the struggles with getting ahead of this based on the incidence rates. If there's two things that we absolutely would be the most critical, can we realistically put people in all of these buckets and expect that we are going to really bend the curve? Or where would we be best to put our resources if we had to just say, these are the two areas?
So the first thing I would tell you is that we need to put pressure from a policy perspective on the state. That's what I will bring to you, because that will make the most impact in not just our community, but communities around us. So that's the first thing. I think we've already assigned people to where our needs are. So a good example of that is looking at the priority populations plan. We know that we have high percentage of Latinx community that are disproportionately affected with this. And we've put some resources and shifted resources into that. That's moving forward. The second thing is what you heard Indira talk about. We cannot get to all of our contact tracing. We can't not control our way from a case investigation and contact tracing perspective out of this. So focusing our resources on those highest priority populations that are going to have the greatest impacts, and focusing on those, and not being able to get to some of the populations that are not going to be as greatly impacted are the areas that we've already shifted into. And I think those are the places that we need to continue to do that. We can't expect everybody to do everything. It's not going to happen. We know that. We know we're going to have challenges with enforcement. So spending a ton of time trying to get our police officers to enforce on this when they're already facing challenging situations in our community is not going to be very effective. We are putting time and effort into public education campaigns and trying to get the word out there more. Multiple presentations in multiple different places with an expansion on that across the metro area. And then a focus on making sure that our school districts are taking as much as they possibly can associated with school outbreaks is the other places that we are focusing. It is, our school districts could make different decisions after they leave on Thanksgiving break, depending on what our numbers look like moving forward. And we're just going to have to be working with them to figure out what that might look like. And then I'm going to stop there and open it up to anybody that's on the phone at this point to also contribute to your thoughts relative to that question as well. Susan has her hand up.
Go ahead, Susan. You might be muted if you're talking, Susan.
Thank you, Greg. Sorry about that. I just wanted to echo what Jeff was saying on the policy challenges with the state. I mean, we are still in a state that has wide diversity. We had a pretty certain election result, obviously, this Tuesday, but you know, the executive branch is very wary, very tepid, very hesitant. And I think that all levers that we're able to push, whether it's Metro directors, whether it's foundation, whether it's community, that we need to think very, very constructively and actually boldly about how to press those levers and get some more proactive results from the state, because the policy action has been way slower than we would like over many months and in a number of arenas with a number of different examples.
Thank you. Okay, well, if everybody's okay, we will complete this agenda item and move on to the next. Going, calm. Okay. Thanks for that update. It's really important, and, you know, give our appreciation to all of the staff. I mean, this is incredibly difficult, stressful, not only in work, but outside. And just let them know that we're thinking about them, and we will be listening to your recommendations to us.
Thanks, Greg. I think that even a message like that from the board to our staff, just to acknowledge that you're aware of the challenging situations and this hard work would go a long way.
Okay. So item 6 is the director's report, which it looks pretty slim considering that a lot of people are probably diverted to COVID. So it's understandable. Any questions from the board members on the director's report? Or Jeff, anything? I guess I'll start with you. Anything you want to point out?
No, nothing that I'll call attention to at this point.
Okay. Any questions from the board? Okay, I'm not hearing any, so I think we're all just processing all that information. So any old or new business, any announcements from the board members or management? Okay, folks, I think this is a good time to adjourn this meeting.
Thank you all for your support. It's much appreciated.
Thank you, Jeff.
Thanks, everyone.
Okay.
Thank you very
Take care.
much.
Stay safe, everybody.
Thank you.
Thank you.
Bye.